Welcome to the NABI podcast. I'm Dr. Amrita More, Associate Professor in the Department of Burns and Plastic Surgery at Safdarjung Hospital, Delhi. And today we have with us a very eminent guest, Dr. Karoon Agrawal. I'm very happy to introduce Dr. Karoon Agrawal, who I have served residency under. And Sir is a well-known figure in the entire country. He's the past president of APSI 2016. He's been the president of Indian Society of Cleft and Craniofacial Surgery in 2008 to 9 and National Academy of Burns in 2009 to 10. Sir is also the recipient of APSI Outstanding Teacher Award 2024 and the National Teacher Award 2015. Sir, we are very happy to welcome you to the NAVI podcast.
Thank you.
So the article we'll be discussing today is titled An Innovative Approach to Classifying and Treating Axillary Scar Contracture. It is authored by Dr. Chen and Dr. Wu and Dr. Chen Zi Yu and Dr. Chen Bi. This paper is from China, from the Plastic Surgery Hospital, Chinese Academy of Medical Sciences and Peking Union Medical College, as well as the PLA General Hospital, Fourth Medical Center, and Chinese PLA General Hospital. So this paper is about axillary scar contracture. As we all know, axillary scar contracture impairs shoulder function and daily activities of daily living, and most require surgical intervention. And these should be treated early and managed with Z-plasty, skin grafting, local flaps, or free flap. What we lack is a consensus on the standard treatment protocol for each type of axillary contracture deformity. So the aim of the study was to define a comprehensive approach to correcting axillary scar contracture to improve the patient outcome. And the basis was the Ogawa's original classification scheme of 2023. The objective was to establish a new classification and treatment algorithm and to in the treatment of axillary contractures. So this is the Ogawa classification, which was proposed in 2003 based on a study of 100 patients that they had treated. So this is divided into mainly two types: contractures within the axillary area and contractures extending outside the axillary area. Within the axillary area, it's further classified into small contractures, which is involving the skin and sparing the fat layer underneath. And then type 2AB, which is the band contracture of anterior and posterior axillary line respectively. And type 3A and B, which involves both the axillary and posterior lines with involvement, without and with involvement of the area between the axillary lines. Type 2, which is the contracture extending outside the axillary area, is again classified into 4A, B, and C. A being contracture extending to both chest and upper arm with no contractures on the back. 4B being contractures extending to both the back and upper arm with no contractures on the chest. And 4C is contractures extending to both the chest and back with no contractures on the upper arm. And type 5 is extensive contractures except type 4. So, sir, what do you think? How important are classifications of burn contractures for the management of burn contractures of the axilla?
Classification is important if it is relevant to management. And that's why most of the classifications, they describe axillary fold separately. Yeah. And axilla is a unique area of contracture where there is a hair-bearing area in the center. And the level of the skin surface is quite different in axilla. There are two folds and the axillary dome is there. That's why the contracture, when it forms, is unique, because sometimes only folds are involved. Sometimes fold and the dome are involved. Sometimes both the folds and dome are involved. So there are too many permutation and combinations in axillary contracture. But classification which has been proposed for the first time was by Dr. Hanma Das in 1986. This was not very popular because the classification which he described was not very explicit, because he said diffuse involvement in type 2. You can see type 1 is linear contracture, that is clear. But linear contracture of what? Is it the axillary fold, or it is involving the dome, or it is not involving the dome? That was not very clear. Type 3, he says it is both fold, and then type 4, it says both folds and diffuse. Diffuse means it could be chest side, it could be back side, or
all in all, it's not very explicit.
Not very explicit. That's why it didn't become popular. But next to that, in 1989, Hakusupu started little better classification. This we had read earlier, but we did not give too much of importance, because immediately after this, next year, the most popular classification of axillary contracture was described in 1990 by Kurtzman. So Kurtzman and Stern classification is the commonest classification. And this really describes very well, but it is limited to the zone of axilla. Just like type 1, it says axillary folds, anterior axillary fold. Type 2, type 1B says axillary posterior fold of the axilla. Type 2 involves both the axillary folds, and type 3 involves dome and the axillary folds. There cannot be contracture of only dome. It has to be along with the axillary fold as well as the. But this is limited to only axilla. But after that, the clinical classification which you Ogawa's classification which you talked over, majority of them will have involvement of the neck, involvement of the chest, axilla, this chest and scapular area. So that becomes more relevant. That's why classification is very important to know, to describe the defect as well as for planning the surgery in future.
So the classification that the author has proposed is divided into two: axillary adjacent region contracture and extended area contracture. The axillary adjacent region contracture, similar to the Ogawa classification 1, is divided again into A, B, C, D, and E. 1A being scar contracture of the anterior axillary wall, upper limb, and lateral chest, as they all commonly occur together. 1B is involving the posterior wall, upper limb, and lateral chest. 1C involving the dome, and D involving the axillary anterior wall, posterior wall, lateral chest, upper limb, as well as, but the axillary dome here is normal. 1E, there is scar contracture of axillary anterior wall, posterior wall, lateral chest,
all the, including
as well as
an
abnormal axillary dome. And extended area contracture, they have again classified based upon the area which is involved. 2A being the neck and the chest, B being elbow, C being the scapula, and D being the waist. And E is the adjacent areas as well as the extended areas in combination. So he had around 196 participants, and he treated 23 axillary contractures.
This author's classification is exactly like Ogawa, except for extension of the area to the neck or elbow, which was not part of the Ogawa classification. So this is going beyond the area of axilla, chest and the anterior chest and the scapular area. That's the only difference. But I think this is quite explicit and it is quite relevant, because if I remember my cases which I have dealt with in last so many years, majority of the axillary contracture, not all, but majority of them have got associated neck contractures, especially adults, and in females you have the axilla. So this is quite. Classification he has proposed was based upon his experience of operating these 223 cases. The ages range both pediatric as well as adults, and most of the patients were and a good distribution between female and male. And the most common cause was burn, that was in 104 cases, and 59 cases of scald, and 33 cases of trauma. The shoulder abduction before the surgery ranged from 10 to 20 degrees. So these are the various regions of the axilla. So do you agree with the areas he has included in the classification? Yeah, this is, as I said, the classification has evolved over time, and the classification started incorporating surrounding area because of the experience which surgeons had. Earlier, it was limited to only axillary fold and the axillary dome. Now we have included, this author has included right up to the neck, right up to the chest, down below to the waist. So this is quite relevant. And this is quite explicit that he has pointed out 1 to 9, all the area right from elbow down to the waist. So in our residency, we used to study primary contractures and secondary contractures. So this could be an extension that they have included primary and secondary both in the classification. You can say that, but actually we never used to define, means it's very difficult to define what is primary, what is secondary. We always, there is a lot of overlap. Right. So this, if you consider the region wise, the away from the axilla, if you include in classification, then you can give away with the primary and secondary word, which is not very explicit. Right. It causes a lot of confusion in our description of the cases. So this is a natural evolution and probably better than describing it as primary and secondary. Absolutely. That's what I feel, that it is much better. So this is the treatment approach the author had. He mostly used local flaps, and the most common being lateral thoracic, transverse scapular artery flap, and lateral scapular artery flap involving the contracture area, and cervical superficial artery flap, medial upper arm flap, LD flap, Z flaps, as well as a combination of all these flaps plus or minus skin graft. So type 1A contracture, that is anterior wall and upper limb and lateral chest wall. As we can see in the data, we mostly use Z flap, lateral chest wall flap, and in some cases he has used the medial arm flap. So, sir, how often do you think a Z plastic can correct contracture? See, type 1 contracture where only folds are involved and linear contracture is there, it might extend from elbow to waist, or it may remain limited to only area of axillary fold, Z-plasty is very good. But now you can say Z-plasty, or you can have square flap, you can have VY plasty, but these are all different nomenclatures or different designs of the same principle, where horizontal tissue is transposed to the vertical direction. But these local flaps are of immense use in axillary contracture.
Type 1B axillary contracture, that is the posterior wall, upper limb and chest. Also, he used the similar flaps, Z-plasty and medial upper arm. So these are, I think, the workhorse flaps as we can see from the data. 1C was again involving the axillary dome. Sir, what do you think is the main challenge we face in managing the dome contractures?
Yeah, the axillary dome has got a special characteristic because it has got hair bearing area. And second, the level of the axillary dome is different than the level of the axillary fold, as I said earlier. That's why the contracture is of different pattern out there. So when the contracture pattern is different, the management is also different. Because aesthetically, axillary hair bearing skin should remain at the dome, top of the dome. And if you release contracture on one side, the hair bearing skin may shift to the other side. So that is aesthetically not acceptable. And if you want to have release in the middle, you have to sacrifice the hair bearing skin. Then only aesthetically it will be acceptable. That's why it is very unique, and it gives a lot of challenge sometimes in planning. Whenever there is this axillary dome is not involved, then it becomes challenge for the surgeon, especially if both the folds are involved and axillary dome is having hair bearing skin. So one has to plan aesthetically that the axillary dome skin, when it is hair bearing, it should stay in the place where it should be. That's why it is a challenge.
So in the data that he has presented, the author has used Z-plasty, medial arm as well as lateral thoracic flap. This is a case in which a lateral thoracic flap has been done. Sir, this flap is most likely a perforator flap because we cannot see a pedicle. So do you think it has an advantage over local flaps?
Yeah, actually, these are all now, since the perforator flaps have been revised, the whole paradigm, the selection of flaps have changed.
Yes.
Because you can manipulate this perforator based in the way you want to have. I don't agree with this author in specifying that this particular flap can be used only for the anterior axillary fold or this can be used only for the posterior. All the flaps which are available in our armamentarium, it can be designed to be used as per the choice of the surgeon and the area involved. So it's a matter of surgeon's choice, because I am not very happy with thoracic flap.
Right.
So I'll use the parascapular flap or scapular based, the subscapular based flap. So I am very happy with that. So that can be used in the posterior axillary fold. It can be used for the upper part. It can be used for the lower part. Similarly, it is all interchangeable.
Right.
But this author has specifically used the specific flap in specific zones, so it is his choice. But definitely perforator based flap has definitely changed the system of choosing a flap. Because pedicle flap, we had reverse planning. We used to struggle to plan for the flap, but here it is not required.
1D, that is contractures involving the anterior wall, posterior wall, but sparing the axillary dome, and some involvement of lateral chest and upper limb. Again, the flaps used are the same, sir.
Yeah.
So in this, we can see he has done Z-plasty of both anterior and posterior axillary folds. And it appears that the author has used tissue expanders in the chest area. Sir, what do you want to comment on use of tissue expanders for contracture release and resurfacing?
Now, so much of tissue is available around, especially in axilla. Unless you are really struggling to get tissues, I think tissue expander is not indicated as far as my experience is concerned. That tissue expander is not very patient-friendly technique. You require 2 major surgeries, and then the patient has to visit every week for the inflation. And then you have to design the flap before you put the expander.
Yes.
So maybe if it is cosmetically, if it is required, aesthetically, if it is required to generate normal tissue, if it is available, one can use. But in our kind of patients, probably it is little too much to offer as tissue expander for the axillary contracture.
This is again when the axillary dome is involved.
Yeah.
So here, he has used mostly single transverse scapular flaps. So we can see a predominance of scapular flap and superficial cervical flap for managing these patients.
This is correct. because transverse scapular flap, because once the dome is involved, you are going across the axillary fold in the axillary dome. So any flap which can be placed horizontally, just like I said, our workhorse was parascapular pedicle flap. Yeah, so it is the pedicle is right and at the posterior axillary fold, and then you come across the dome. Wherever dome is involved, I think parascapular flap has got great role to play in axillary contracture, and we had used in large number of patients.
In the study, the author says that transverse scapular flap he preferred in many cases because he said that even when the overlying skin was burnt, the artery was usually preserved because it's relatively deep lying. And he has raised quite a few flaps, he says, from the scarred skin adjacent to the burn. So do you think, how safe do you think it is to raise flaps from scarred skin, and when should we avoid doing it?
If I'll answer the first one, second one first. When to avoid? If it is a deep burn to the extent of involving the subcutaneous tissue, where you don't expect the perforator to be surviving well, or it is skin grafted area, one should not use. But if you are using a perforator based flap and it is only the skin is lost and it has healed with secondary intention or with this thin split thickness graft also, you can use, provided the vascularity of that area is preserved well. And one will always like to avoid scarred tissue as a flap. But if you don't have any normal skin, you can use scarred flap. But one has to be ready for the eventualities. You should be little more careful while transferring that your dermal bleed is adequate or not. So, but it can be used in some cases.
So after assessing dermal bleeding and with knowledge of the previous history of the patient, how the area has healed, we should decide.
Yeah, especially if you have got electrical burn or if you have got the chemical burn in that area.
Want to do it.
Yes. If it is scald, then I will not be worried about it.
Right.
Because scald will usually involve only up to the dermis. So that can be used very safely because the subdermal plexus and the perforators are intact.
In electrical burns particularly, it's very tricky. How will we, do you recommend use of Doppler, and do you recommend any, how safe is it to use local flaps for electrical burns, especially in the
If it
axillary?
is healed area, if it is secondarily, if we are doing, and if you have the information about the depth of burn at that time, one can use provided your perforators are intact.
Yes.
And only way to know perforators are intact is transcutaneous Doppler.
Yes.
Or if you can have color Doppler if you have got good lab and especially cardiac center, you can get the color Doppler. And you can have MRI or CT scan. But for contracture, doing all these things may not be really required.
Probably an overkill.
Yeah, it will be overkill. Probably you can manage with other procedures or skin graft rather than going for the flap. You don't need to really struggle hard to do some local flaps wherever you don't have the armamentarium.
So we could consider free flaps maybe.
Yes, right. I think we should have talked about it. Free flap is a place where you are asking the question. Wherever the local flap is not available or you are worried about the tissue loss because of the electrical burn or deep chemical burn, probably the free flap is the answer in such situation. And you have got a lot of leverage. Maneuverability is there. You can plan very easily.
Yes.
And you can harvest large amount of tissue you can transfer without any complications.
So now moving on to contractures of 1E. I think we've already crossed this. Now coming to 2A. So 2A is extended area contracture. This child is having contracture of the chest and neck area. And this has been managed with multiple modalities with the author has written that they have done multiple Z-plasties as well as 2 flaps and has achieved a fairly good result in an adult life. So pediatric patients are particularly, would you have any reservations or considerations in the planning of the treatment?
Usually, post-operative management of pediatric patients is not very easy.
Yes.
Especially keeping a splint or massage or keeping a pressure garment is not very easy. So one should always try to do a flap as the primary procedure, especially in the area of the joint, in the central part of the. If you are doing Z-plasty, then it is fine. But if you are doing a graft versus flap, if you say, I will prefer to plan a flap, so that full thickness coverage is there in the area, so that the patient doesn't require too much of post-operative management. So that's a major consideration. But other consideration is usually pediatric patients will have usually smaller contractures. They will either have the axillary fold contractures anterior or posterior or only anterior posterior. Very few of them will have dome involvement because they are exposed usually to scalp or the thermal burn or lighter variety. So that's why usually severity of contracture, which I remember in my career, were much less severe as compared to adults. In adults, we usually see multiple contractures on both sides of the axilla, including the chest, including the neck. Very severe, like the grotesque figure kind of thing you will see in adults, but not in children, not very often. They also come sometimes, but not so often.
So what about the thickness of graft? Like in cases where we are using thickness, pediatrics would we want to go for FTG instead of an SSG?
That depends on the dimension of the
Yes.
recipient area. If you can manage with full thickness, if you have got enough full thickness graft, if it is possible to come, definitely it is preferred. But if it is not available, then you can manage with the medium split thickness skin graft. Another thing is if one can afford, it's better to go, especially in children with the terminal substitutes. Now we have got availability of this. Only cost factor is the one which is limiting factor, especially in government institutions. But if it is possible, one can use that. And it is as good as full thickness graft and almost in between full thickness graft and the flaps.
In 2B contracture, that is involving the elbow region, the author has managed with mostly Z-plasties extending to the elbows, plus a local flap to address the axilla. And the most common flap here, the most common procedure done here is Z-plasty only. And a few cases of flaps like superficial cervical flap or single superficial cervical flap, or even along with the skin graft.
As I said, these are all personal choices and availability. And if it is linear contracture, definitely everybody will use only local Z-plasty or VY plasty or square flap or something, whatever. But I don't think we need to narrate what flap, what procedure should be used for a particular patient.
So extended contractures where the scapular area is involved. Again, this is also mostly the similar flaps have been used as in all
Actually,
cases.
these are all same flaps.
Yes, sir.
Which has been enumerated. Only the number is different in different types of patients.
So this is the scapular area, and again the waist flap extending to the waist. This is a diagram showing the linear band extending up to the waist for which Z-plasty has been done. Again, similar flaps are used. This is 2E. This is where the axilla is involved plus the more than two adjacent areas are involved. Here he has probably a higher incidence of skin necrosis and flap necrosis compared to the other tables as we have observed. And he has again used flaps as well as the grafts. And
actually, if you see, these are all scar-based flaps.
Yes, sir.
These are all cicatricial. What he has said is cicatricial flaps. That's why he has got more of complications and
Yes,
skin
sir.
necrosis. So this is bound to happen in cicatricial flap, especially it looks like a deep burn primarily. So in these cases, it is anticipated, but he has managed well and the outcome has been very impressive.
In this patient, he has used quite a few latissimus dorsi flaps also, which was not the case in the less severe contractures. Sir, how often do you think we require a LD flap for?
I'm not very much fond of latissimus dorsi flap because it's very bulky. And we did earlier in late 80s when latissimus dorsi was introduced, and we were thrilled to do axillary contracture release using that flap. But patient comes back saying that he cannot adduct. And you can understand, you can imagine there is a big bulk in the axillary dome. Instead of dome going up, it comes down and then it obstructs the adduction of the axilla. So it is not the ideal flap. One can have perforator-based latissimus dorsi tissue flap, which he has called as lateral thoracic flap.
Yes, sir.
Basically, lateral thoracic flap is latissimus dorsi perforator flap. So that can have a lot of maneuverability and it can be used in such situation.
So in post-operative care, all patients were instructed to immobilize the affected shoulder at a 90-degree angle, and functional exercises started after a 2 weeks healing period. Other than this, patient author has not specified any other modality for managing the post-operative. So do you agree with only exercise being adequate for?
I don't think this is adequate. In our practical experience and our experience of all treating all these patients, we always use comprehensive care for scar post-operatively. And I think I'll wait for 3 weeks rather than 2 weeks before I immobilize, especially in the junctional area when it is there or the skin fold, probably it might break down after 2 weeks. So I'll wait for 3 weeks, but I will use the pressure garment. I will use figure of 8 pressure technique by which we can give pressure over the axilla. I'll use massage. I'll depend on massage as much as any other thing. And of course, the exercise and overhead abduction exercises, forward movement of the limbs, backward movement of the limbs, all these things need to be exercised. But I will add on to this method of post-operative care by massage, pressure garment, as well as figure of eight.
Equal emphasis on all the other.
More than that, because you cannot control exercise,
Yes.
but you can control the pressure garment in the other methodologies.
So author used 133 out of the 223 cases required a flap reconstruction, and 63 received a skin graft along with the local flaps. And at 1 year follow-up, almost all patients had 110 to 180 degree abduction, except 23 cases which had recurrence, which author attributes to not following the exercise regimen, and 5 of which needed surgical intervention. Among these 23 cases, there were more pediatric cases than adult cases, and 15 patients had flap issues, of which 11 patients had skin necrosis.
So these are all very clear in his results. Very nicely, he has accepted whatever shortcomings are there in his procedure, because skin necrosis occurred mostly in the cicatricial flaps. What is glaring in this list is he has not used exclusive skin graft for any of the patients. In 223, he has used all local flaps.
Yes.
And wherever leftover area is there, he has used the skin graft, which is not in our practice. We use skin graft in much more frequency. And even if I remember my cases or my experience, almost 50% of axillary contractures I have released exclusively with skin. That is a glaring difference between our practice and this author's experience.
This is one of the points which even the author has said, that this is the reason why he said we needed to move on to a newer classification, because Ogawa in his paper had said that of majority, almost all, I think he had released with skin grafting.
Yeah.
And whereas he has done exactly the opposite and released mostly with local grafts, and that's why he proposed the entire.
And it is very good to see that he has learned out of Ogawa's paper so much that he has transformed the management of the axillary contracture to the extent that we should learn out of this paper that we should always insist on local flaps, because now with knowledge of perforator, we can design many flaps. And if it is not available, better to use free flap, because it's there in everybody's armamentarium. And we should avoid relying on exclusive skin graft for any contracture it is, not only axillary contracture, but it's same for any other areas. We should avoid using this.
So from the paper, we can gather this, that considerations for the type of defects before management, we should see what are the areas that are involved. So essentially the defect created after the contracture release would be either having a predominantly longitudinal component or a transverse component, depending upon the areas involved. So a longitudinal components would be due to...
This is very clear.
Yes, sir.
In any contracture you release, it will have two dimensions.
Yes, sir.
Either horizontal or horizontal or transverse, or it will have longitudinal. But in axillary contracture, it is very essential to know this, because even if it looks small, axillary contracture, when you release, invariably longitudinally it will be quite large, which is very difficult to assess pre-operatively. So one should always be ready for a tissue, the flap or tissue, which should cover much larger area than what pre-operatively you are able to see. And it is good that you have to understand it is longitudinal or it is transverse, because the placement of your flap pedicle will depend on that. But actually, if you see the choice of the flaps, the surgeon says that I will use only specific flap for a specific. I don't agree. This is all surgeon's choice and availability of a flap and normal tissue. So you can design, and then you can permutation combination you can use. So I think specific choice is not required, but definitely it is well taken.
So this is the algorithm he has proposed. Again, what we went through in the tables as well. Z plus T is being the most common, and when required, he has used other flaps. And lateral thoracic flap, I think the author has a preference for lateral thoracic flap. And LD he has used in very few cases and tried to avoid skin graft as much as possible.
Not as much as. He has avoided exclusive skin graft. Yes. He has added skin graft as a secondary procedure.
Yes. So essentially the principles in selecting the flaps are, as per the author, the pedicle should be in close proximity, as we have discussed. And upper axillary defect, he has preferred to use transverse scapular flap. and superficial cervical artery flap and medial arm flap. Whereas the lower part of the axilla, he has preferred lateral thoracic flap because of the proximity. And for large defect only, he has advised LD flap. And SSD only as an additional procedure, and choice is not absolute, as you mentioned, and surgeon's preference and experience counts. And the goal is to finally restore the patient function.
And, this article is specifying about the perforator based flaps.
Yes.
But in our armamentarium, we should not forget that there are many other flaps which are available with us. Pedicle flap, also the LD flap he has used as a perforator kind of flap, the islanded flap he has used. But just like parascapular flap I was talking. Parascapular flap is a pedicle flap, but it has robust vascularity because the subscapular pedicle is just below the pedicle. And the placement in the design is such that you can raise beautiful flap report, and it gives aesthetically beautiful result. So what I mean to say is we should not forget the pedicle flaps which are available with us. Just like epimeral artery based flap, you can raise from the pectoral area and you can transfer from anterior to posterior. So there are many other options are available, but we should expand our armamentarium, which this author has rightly done with the use of local flaps.
Again, scarred flaps, he has rightly said that it reduces the tissue elasticity, the scars, and may be a post-operative functional limitation. And donor area closure can be difficult. And free skin graft or free flap should be considered in these cases, like you said. So finally, in conclusion, the principles for treatment of axillary contracture is that simple and effective method should be used. Local flap should be preferred, and donor side should be closed directly. And skin grafting, he has said no skin grafting, but it should be avoided as much as possible. And scarred skin flap should be used judiciously, like you said, and local flaps should be selected based on orientation. And post-operative functional exercise must be adhered to. To this, we must add the other modalities are equally important. And only skin graft is not a rational choice, which you rightly agreed with, sir. And scar is the axilla and adjacent part should be considered in planning, the management. So only the axilla should not be considered in that.
That is the strength of this paper, that he has extended.
Yes.
He has extended the classification which has been described earlier, and he has added the extended area. That's why his result has been so good. And this proposed classification is, though it is copy of Ogawa's, but it looks like it has proved its worth by showing the result and involving the extended area. And he has given very good clinical examples. If you see all types, he has given clinical example with the outcome. It is not only the question of only intra, he has given the long-term result as well. So it is quite impressive paper that way. Though I felt that in discussion he should have added the other techniques which are available for management of the contracture, which we discussed between ourselves.
So what do you think, sir, are the weaknesses of the paper?
That's what I said. Weakness is little less emphasis on the axillary dome. He has not talked about the hair-bearing axillary dome, especially while designing in type 1D type of contractures. He should have specified that because of the hair-bearing, that particular terminology is not existing, which we emphasize that the surgeon should know about the intricacy of the axillary. As I have added some of the other flaps,
Yes.
the perforator-based flaps which he has described, they are very good, but they are not sacrosanct. We should add on to our armamentarium. And I felt in this, though he has given good number, 233 surgeries in 199 patients, but there is no statistical analysis.
Right.
So what is the percentage of cicatricial flaps landed into problem? Number he has given, but there is no statistical analysis. So I think that part also needs to be looked into. So these are the weaknesses of the paper, which I think he should have taken care.
Thank you very much, sir, for the elaborate and comprehensive discussion on postponed contracture of axilla. And we are much benefited by your expertise and your immense knowledge on the topic, sir. And thank you very much for being a part of the podcast again.
Thank you, Amrita. Thank you so much.